Thank you, Dr. McMahon. And we have Dr. Basinski here. So I'll start with a question for you, Dr. McMahon. And one of our learners asks about the use of cystatin C for estimating GFR. And if we're using that, will that lead to more patients being initiated on dialysis? Presumably because the GFR may be lower when we use cystatin C to assess the GFR.
Well, I mean, my own personal practice these days is once you get down to that level of GFR is to kind of ignore what the GFR is to some extent. You know, the studies have shown us that initiating dialysis early is not associated with any benefit. And so I tell my patients that I'll start them on dialysis when they ask me to, when they have symptoms or when, you know, their metabolic complications become overwhelming and they aren't able to stay off it anymore. So I don't necessarily think that using cystatin C is going to change that all that much. And the other part of it too is I think once you get down to that level, you know, the changes are so small and so subtle. It's like it's probably not going to make that much difference if it's 8 versus 10.
Great, thank you, Dr. Basinski.
Yes.
One learner asks, what binder would you give to a dialysis patient who has a low calcium, a high phosphorus, and a high PTH? Would you give a low dose calcium binder? I'll just add that in my clinic, my dietitian often comes to me with a patient who has, you know, say calcium in the high 7s to low 8s, and sort of encouraging calcium-based binders. But based upon the presentations that I've heard from you, I tend to stay away from those. So, what are your thoughts?
So, it's a great question. It's clear that you don't want to give excess calcium. Some of that calcium will be absorbed. Some of that calcium will accumulate in the soft tissues. And as I've mentioned, blood calcium is not a fuel gauge for how much calcium is in the body. You can have extensive vascular calcification and have a low serum calcium. That said, when the calcium gets really low, especially if there are any symptoms, you have to treat. So I always use non-calcium-based binders. I try never to use calcium-based binders based on in my mind, overwhelming evidence. By the same token, if someone's having symptomatic hypocalcemia or even, you know, really low calcium, I'll use a little calcium-based binder. But I try to stay away from it. I also look at PTH. I also look at vitamin D. I also look at their diet. And what are they eating and how high is the phosphorus? So you have to, this is precision medicine. You have to be a good doctor and not use calcium if it can be avoided, but you have to when you have to. Thank you.
Great, thank you. Another learner asks, what about tenapanor for all dialysis patients? And I'm going to modify that slightly and say, what about for all dialysis patients with a high phosphorus?
So I showed the data. Tenapanor is remarkably effective. It works on a different pathway. See, our binders bind calcium in the intestine. This prevents the reabsorption. Binds phosphorus in the intestine. This prevents the absorption. So tenapanor works, but the side effect profile isn't benign. It was used for irritable bowel syndrome, and some people have unacceptable side effects. But if there's no bad side effects for your individual patient and it gets the phosphorus down, I'm all for it, especially if their insurance covers it, because sometimes it doesn't.
Thank you. So I'm going to ask a question that is really directed towards me, but I'm going to ask my colleagues to weigh in as well, because my answer is going to be largely opinion-based. And the question is, what do I think is the optimal dialysate bicarbonate concentration? This is an opinion-based answer because I don't think that we have great data to say what the optimal bicarbonate concentration is. So I tend to say I try to avoid those very high concentrations of bicarbonate, i.e. 38, because the total buffer is then going to be 42. So I tend, to the most part, to stick to 35. And in patients who are malnourished, who may have pre-existing metabolic alkalosis, I will occasionally modify it and bring it down even lower. But for the most part, I would say for the average patient in the chronic outpatient unit, I generally go with a default bicarbonate concentration of 35, understanding that we're using the liquid acetate concentrate, and so the cold buffer is going to be 49. Dr. Baczynski, your thoughts, and then Dr. McMahon?
Okay, I'll go first. I agree with you completely. We know that calcium phosphate precipitation is pH dependent. And if you make the patient too alkalemic, they're going to deposit calcium phosphate, which is apatite, in their systemic circulation. So you really don't want them to be alkalemic. You also don't want them to be acidemic. So 35 seems like a good compromise. So I agree with you completely.
Dr. McMahon, any thoughts?
Yeah, I mean, my thought on this always has been the problem with manipulating the bicarb in that situation is it's kind of putting a band-aid on what the real problem is, which is the lack of nutrition in some of these individuals. And I wonder how much the increased mortality is due to their underlying factors rather than the fact that they're alkalemic. And while yes, it just feels like if somebody is truly running a pre-dialysis bicarb of 28 or 29 or 30, doesn't mean that they're alkalemic all the time, though, as well, because, well, no, that's not true. I'll take that back. It does mean they're alkalemic all the time, or at least they're very alkalemic after dialysis. So I take Dr. Baczynski's point that it's not going to be good, but I've always worried about the fact that when we do that, we're not really dealing with the underlying issue.
Yep.
Great. Dr. Baczynski, do you recommend measuring 25 vitamin D levels and supplementing D2 or D3 on dialysis patients given the pleomorphic functions of vitamin D?
Well, so that's a great question. Vitamin D has gone from everyone is vitamin D deficient and everyone needs copious amounts of vitamin D to cure everything. And clearly it's not. It doesn't. Every controlled study of the precursor 25D has been negative. Giving vitamin D doesn't really help. That said, the endocrine people talk about levels of 20 of being sufficient. If my patient's below 20, I supplement it just because you want to have sufficient precursor to hydroxylate the 25 and 125. So I measure it. It's easy to measure. If it's below 20, I replete it. If you give more, you can sometimes lower PTH, especially in pre-dialysis patients, but 20 is a good number, and it's not expensive, and so I measure it, and our dietitians really like it because they love giving vitamin D.
Great, thank you. There are a couple of questions that came in for me about potassium baths in severe hyperkalemia. So there's the first question and the second question. We're going to try to combine the two. For severe hyperkalemia, it's the practice of starting with a higher potassium bath and lowering it over time based upon theoretical risk, anecdotal experience, or comparison studies. When I encounter K greater than 8, I generally use a 1K bath for 1 to 2 hours, then switch to a 2K bath. I've been doing this for greater than 12 years without any adverse events so far, and potassium is always normalized after treatment. So I will answer in the following way. So when I was a fellow a long time ago, we actually used a 0 potassium bath in severe hyperkalemia, and I don't remember anyone having a cardiac arrest during that time. But we also weren't doing continuous EKG monitoring. So I think at least theoretically, we know that an extreme gradient, based upon the work of Patrick Pun at Duke and others, an extreme potassium gradient is more likely to induce arrhythmias. Whether those arrhythmias are clinically significant or not is a different question. But we do know that that very high gradient tends to be more arrhythmogenic. And so at least theoretically, it seems like it's probably safer to start with a higher potassium bath and gradually bring it down so that the gradient is gradually increased rather than starting with a very aggressive potassium gradient. So for that reason, I would start with a 3 and titrate down as opposed to starting with a 1 and titrating up.
Dr. Tucker, can I
Yes.
ask, did you also start an oral potassium binder on that patient you presented in the ED?
Did I start an oral potassium binder?
Yeah.
You know, honestly, I don't remember whether I did or not. But if this is someone who I think probably would benefit from an oral potassium binder, if we know that this patient is prone to missing dialysis treatments, whatever
Right.
we can do to mitigate that risk of an adverse event, and so someone who's prone to skipping dialysis, I think that might be a prudent strategy.
Thank you.
So we are at time. So I want to thank Dr. Bashinsky and Dr. McMahon for great presentations and participating in this Q&A session. We now have a break until 2:55 Eastern time. So get your lunch, and we will see you back at 2:55. I'm sorry, is it 2:25? I believe Eastern. Let me make sure before we adjourn. Yeah, 2:25 Eastern time. We'll be back. So thank you, everyone.
Thank you. It's great.
Thanks, Kevin.